இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றவும் நல்லனவற்றை உள்வாங்கவும் மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் எல்லா மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you very much. This particular focus of the month has become very popular, and we have had two major successes in the form of cardiology and in nephrology. They are real hits. So this month we are going to have the third lot, which is the endocrinology. I may request our president, Dr. Balashankar sir, to inaugurate the session.
A very good evening, one and all. I thank Dr. Murugesh, Dr. Thiru and Dr. Palaniraman for successfully taking this program for the third consecutive month, which is one of the very big hit in this forum. Chat with the specialist practitioners. Okay. And we had two topics in the last 2 months, and this month's topic is endocrinology. Day in and day out, if not day in and day out, at least 1, 2 or 3 cases in a week, we encounter some endocrine problem or other, which is a little difficult to solve actually as a level of practitioner. I think one of the very investigation-oriented and little tough problems to diagnose, endocrine problems, I think. That's far as I am concerned. Okay. So, maybe the diabetes and all those things may be a little easier to diagnose. Other problems are a little difficult. So, today we will be having two specialists with us, Dr. Anurag Bajpai and Dr. Akhila. Both are renowned endocrinologists. Anurag Bajpai is an international speaker in endocrinology, and Akhila is very much qualified and senior endocrinologist from Coimbatore. I hope they will all be discussing the common endocrine problems which a practitioner faces day in and day out, and give a clear-cut guideline for the common problems we encounter in our practice. Thank you very much for the opportunity. I am listening, and I am very eager to learn a lot from these two stalwarts today. Thank you very much.
Thank you very much, sir. It gives me great pleasure to welcome our star faculty for the day, Dr. Anurag Bajpai. Thank you very much, sir, for joining us from Jaipur. And Dr. Akhila Ayya, who is the current president of Endocrinology Society of Pediatric Society. Am I right, ma'am?
Yes.
Yes, thank you very much. Sorry. And my special thanks to Dr. Palaniraman for bringing in such a star cast, actually. I mean, this program has really taken, is racking in a lot of views in our YouTube channel also. And so we are very happy to have you here. And my special thanks to the moderator for the day, for Dr. Ramanathan. So thank you very much for joining us, sir. Over to Dr. Palaniraman and Dr. Ramanathan.
Sir, Ramanathan, sir, I welcome you, sir. Sorry, I missed you. Sorry, sir. Ramanathan, sir, please. Sorry. Excuse me. Please welcome.
Thank you, sir. Thank you. Good evening, sir. Thank you. Thank you,
Sorry,
sir. No issues. No. Thank you, sir.
Ramanathan.
Thank you, sir. Over,
Thank you, sir.
over to Dr. Palaniraman.
Okay. Very good evening, my dear friends. First of all, I thank the Office Bearers President Dr. Balashankar and my Dynamic Secretary Tirumurugan and Treasurer Dakshayani for giving the opportunity to do some good thing for mainly the to relieve the at least to actually to that is to remove the ignorance from the people practitioners about the common problems in day-to-day practice. Okay. Now I'll ask the Dr. Ramanathan to mainly introduce the special faculty because he is the chief guest for us today. So I'll ask Ramanathan to introduce Anurag. And another good thing is Dr. Anurag is a classmate of Dr. Ramanathan in AIMS during the
Junior,
post. That is a
Was
specialty.
my junior, sir. Junior.
Junior, right?
So nice.
Who is junior?
So nice.
Okay.
So nice.
Okay. Ramanathan, you go ahead with introducing Dr. Anurag.
Thank you, sir. Thank you, Dr. Palaniram. Am I audible, sir?
Yes.
Warm welcome to all of you for joining us for today's academic session on a really warm Sunday evening in spite of CSK match which is going on. My sincere thanks for IAPTNSC office bearers for giving me this opportunity to moderate this meet along with my good friend Dr. Palniram. I am sure that by the end of this session, we'll have a clear idea and lot of clarity in diagnosing pediatric endocrine disorders, and I'm sure that this will immensely benefit the practicing pediatrician. Our expert for today's session is Dr. Anurag Bajpai, consultant pediatric and adolescent endocrinologist at the Regency Center for Diabetes and Endocrinology Research, Kanpur, an astute clinical endocrinologist and a phenomenal teacher. Dr. Bajpai, a postgraduate from All India Institute of Medical Sciences, has trained extensively in endocrinology at the Royal Children's Hospital, Melbourne, Australia, and the United Kingdom. He has numerous indexed publications and has contributed to endocrinology chapters in several textbooks. His penchant for teaching is evident in the very popular Med-E classes and online continuing medical education platform that he has founded. The platform offers crisp, practical, and most importantly, totally free lectures for medical professionals. On a personal level, I had the pleasure of being Dr. Anurag's senior during our postgraduate days at AIIMS Delhi. I recollect him being a diligent and meticulous student, and it was no surprise that he was awarded the prestigious Catherine Freeman Prize for the best postgraduate in pediatrics at All India Institute of Medical Sciences. Despite many laurels and achievements, Dr. Anurag Bajpai continues to be the same humble and warm-hearted person, and looking forward to hear from him today. Thank you.
Okay, let me introduce Dr. Another star faculty today, Dr. Aguila Hayau, actually, who is my batchmate of 1985 batch. So prestigious 1985 batch, I'm very proud to say. And as well as she's a senior consultant from Coimbatore. She is attached with the GKNM Institute, and she was trained by a great teacher of, actually father of Southern endocrinology in Southern India, Professor Raghupati, and she was mentored by Professor Raghupati. And again, she did fellowship in New Zealand during a period of for 2 to 3 years in New Zealand, and she got the Young Scientist Award during her research. And she's a well-renowned and very practical actually pediatric endocrinologist and very helpful. And whenever we ask any doubts, she is very, very eager to clarify us. So let us start the discussion without wasting much of time. We already had 10 minutes. Okay, now our session we have divided today into 4 parts. The first part is mainly we are going to discuss something about the thyroid, which is the most common thing each and every day. Very commonly a practitioner faces in day-to-day practice with respect to endocrinology. The second part, Dr. Anurag will be actually deliberating on growth and growth charts. And the third part, Dr. Aguila will be showing some spotters from head to foot where the endocrine clues the practitioner should pick off. And the fourth part is the remaining endocrine issues we will be discussing. This is the 4 parts we have planned today. To start with, now I'll start with the question. Anyone of the faculty can take. What are the basic essential tools a pediatrician should have in his consultation chamber mainly to diagnose endocrine issues?
Anurag, you first, please.
Yeah, I think first of all, thanks a lot for this wonderful opportunity and great to interact with so many people, especially Dr. Ramanathan after a long time, Dr. Palani, Dr. Ahila again. And so I think one thing we need to understand is that when we say pediatric endocrinology, we just don't mean specific pediatric endocrinology. Every child that you are seeing needs to be evaluated from a pediatric endocrine perspective, which is very, very important because so many conditions in the inpatient and outpatient will have some endocrine ramifications. So unless we look for it, endocrinology is something which is not there. Somebody will come with a cardiac lesion, they will know that this is cardiology, or somebody will come with jaundice, you will know that this is clearly a case of a liver disease. In endocrinology, you will have to really dig deep to find whether there is an endocrine cause or not. So I would say as a very basic part, of course, the most important tools will be a reliable tool to measure the height, the weight, a growth chart, which can be evaluated properly in that perspective. So a good body assessment and measurement perspectives will be something which is extremely important from a clinical perspective. And next, of course, will be access with regards to evaluation for pubertal assessment. So you need to have an orchidometer and, of course, clinical skills to examine with regards to the examination for girls for pubertal status. So essentially, if you are assessing growth and puberty in a reasonably appropriate fashion, I would say you are mainly looking at most endocrine disorders, and this is what I'll focus on as to how just growth chart, puberty, and third, of course, is bone age will really tell you 90% of your situations in most cases in pediatric endocrinology. So carefully assessed growth plotted on a chart and pubertal assessment is your fundamental requirement, I would say, from that regards.
And okay, now going to the thyroid proper, what is the current screening time and the current values of mainly during screening of congenital hypothyroidism, and how to proceed if the screen is positive? Dr. Aguila.
Good evening, everyone. Thank you very much to the IAPTNSC, Dr. Balashankar, Dr. Tirumurugan, Dr. Daksh, Dr. Panniraman, Dr. Ramanathan, and everyone. So I would say we are actually, we initiated newborn thyroid screening in GKNM from the 1st of January 2006, and I think it's now 18 years into newborn screening. We do cord blood screening, which we are very, very happy with because we don't lose any patients, because quite a few of these mothers are discharged on day 2 if they have a normal delivery and the mom is otherwise well. So you might miss a few. The most important thing about screening, I would say, is that you look at the results. You do the test, but quite a few times it's missed that you don't look at the results. It is imperative that you look at the results. So first, I would say we are doing newborn thyroid screening in a cord blood. Our cutoff is 20. We try to climb up to 25. We were missing a few. So we audit ourselves every once in a while. So our newborn cutoff for cord blood is more than 20. We definitely think of hypothyroidism. We will repeat a sample after 72 hours with a free T4 or a T4 and a TSH. If it is more than 40, we usually assume it is definitely congenital hypothyroidism. And if you cannot repeat, I would just suggest you start treatment. If you are able to repeat, definitely do it after 72 hours and then reassess and then decide what you would want to do. If it is less than 20, we just let it alone unless it's a preterm, we would repeat after 2 weeks.
So if the screen is positive, you ask to repeat the venous blood after 72 hours?
Yes.
For the confirmation, we have to do both free T4 and TSH?
Free T4 and TSH or a T4 and TSH, whichever is available.
Free T4, what are the values do you suggest? Mainly after 72 hours, what are the values you suggest?
Though the IAP ISPE guidelines say 1.17, I wouldn't go along with that number. I would say you have your own normative value for that age. See to it that it is in the upper half of the reference range. It should always be on the upper half of the reference range. So have newborn free T4 values which have normative value for your hospital for that age group, and it should be in the upper half.
Okay. So if the free T4 is more than 1, and as well as if the TSH is less than 10 or less than 5, no problem. So we can say definitely the child is not having any thyroid thing. If the screen is TSH is more than 20, as well as the T4 less than 1, we should take it as mostly we should start the treatment from day onwards. And usually what is the treatment do you suggest immediately to start with? So after confirming the thing, to go further with the further, because we in the periphery, we don't have further investigations to confirm what is the etiology. So whether we have to go for the treatment immediately, because since it is as it is told, it is a medical emergency to start hypothyroid treatment as early as possible. So what treatment you advise as early as possible?
Thyroxine, 10 to 15 mics per kg per day. Always on the nearest to the whole number possible. So I don't like mixing and then taking 1 ml, 1.5 ml. Rather than that, I would actually go to the nearest whole number, give it. If it is, I always try to repeat the thyroid functions after 2 weeks and like to climb down on my dose, though certain centers say it's enough if you repeat after 1 month. I'm also worried about the effects of having too high a thyroid value so early in life. So if you have normalized by 2 weeks, then we step down and go into a maintenance dose. We keep a close watch. Abroad, we used to do every week. Here, I do after 2 weeks. And then again, a month later. And then depending on the thyroxine, T4 and TSH values, we plan our further follow-up. I usually do once a month until 1 year of age, and then every 3 months until 3 years of age. And then beyond that, we decide on what based on the diagnosis.
Thank you, madam. So suppose we have a confirmed case of hypothyroidism. congenital hypothyroidism. Dr. Anurag, is it mandatory to do ultrasound and thyroid scan in all cases? And how is it going to alter the treatment?
I think just to add what Dr. Ahila was saying, just to add with regards to the dosing, I think now we are also following a protocol of FT4 based dosing. So if your FT4 levels are very, very low, they are below 5 picomoles per liter, which is extremely low, we start with the 15. And if it's above 10, which is in the normal range, we start from somewhere around 7 to 8 to 10. And then of course you titrate on that. Coming back to your particular question, Dr. Namanathan, about the need for ultrasound and scan. So these are desirable investigations. These are not mandatory or essential investigations. The most important part is to start the treatment. So if somebody doesn't have a facility for ultrasound and thyroid scan, don't worry, start treatment. You're not doing anything wrong. Now, what we are going to look at in terms of scan, or my main aim would actually be to see whether this child will have a reversible form of congenital hypothyroidism or not. So if you have an absent thyroid on a scan and an absent thyroid on an ultrasound, it means that there is a completely no chance of reversibility. On the other hand, if you have an ectopic thyroid on a scan, that again means it's a permanent cause. If you have a eutopic thyroid, either on an ultrasound or on a scan, there is a possibility that you may have a reversibility. So rather than, if you go from a diagnostic purpose, of course, you will say we want to have a scan and an ultrasound. But from a clinician's perspective, where the focus is today, I would say the main role is with regards to reversibility. So you can start treatment without doing those procedures. Sometimes scan is not available. You want to do scan after some time. So if your TSH is about 30, you can still do a scan. So it's no harm starting, because if somebody's TSH is more than 100, it may take time to come down to 30. So to answer your question in a single word, no, they are not essential, but they are really going to help you out in terms of long-term management and prognosis.
Okay, doctor. Thank you, Dr. Anurag. So, Dr. Palaniram?
Yeah, if it is Anurag, if it is a high risk like situations, for example, preterm babies or hypothyroid mothers, particularly they are more prone for false positive or false negative screening during the newborn period. What should we do?
Yes, so very important. Dr. Ahila has mentioned a very important point, that if you have a preterm baby, if you have a sick child, if you have a same-sex twin, these are the clear-cut indications that you might need to repeat the test after 2 to 4 weeks. So in these cases, you may have a false negative because of a delayed rise of TSH. Now, maternal hypothyroidism, I would say usually you should be able to pick up in the initial screen. There is no recommendation that if mother has hypothyroidism and your TSH is normal, you repeat after some time. But yes, if somebody is premature, somebody has trisomy 21, somebody is sick, and somebody has a same-sex twin, those situations you repeat after 2 to 4 weeks. That's a very, very important to not miss it in that regards.
So message is to repeat after 2 weeks in high-risk situations like prematurity, sick babies, as well as maternal hypothyroidism. For example, what are the chances of missing congenital hypothyroidism by screening? For example, sometimes we come across situations that is newborn screening is negative. By 6 months, the baby develops features of hypothyroidism. These chances occurs very rarely. But what are the chances? Screening is negative during the newborn period. But by 6 months of time, by 6 months, you get the features of hypothyroidism in the baby. And finally, the baby turns out to be having a dysharmogenesis or ectopic thyroid. So what are the chances like this happening in this case? Because the parents can ask, why, sir, you have done the screening, but how you have missed the diagnosis in this situation? How legally we are safe?
So so outside the purview of these conditions I talked about, the chances are extremely less unless there are issues in terms of the assay or sample collection. So generally, these are the most common ones. As Dr. Ahila nicely said, prematurity is most important. Dr. Ahila, in your experience, what are these sort of situations beyond these in which you have a false negative screening? Because I haven't encountered much unless the assay issues are there.
No, I have seen a few Down syndrome.
Yes,
quite
Down
frequently Down syndrome. And sometimes an ectopic thyroid, they may be producing enough initially and may gradually evolve into hypothyroidism. And in these, for everybody, I always say, even though you should remember it's a screening test, it's not a confirmatory test that you're doing. Anytime a pediatrician, that's why I always prefer a pediatrician to do immunizations. During your first immunization visit, if you suspect congenital hypothyroidism, please repeat the test. There are some forms of slowly evolving hypothyroidism. Even partial dysharmogenesis may evolve slowly. If you suspect, you have to repeat. But Down syndrome is one situation where I actually see evolving hypothyroidism a little bit slowly.
That is a very good message, madam. Thank you. Especially in Down syndrome and those who have hemiogenesis of thyroid, I think the sample has to be repeated. Madam, can you just stop sharing your screen? And thank you. So, in what cases can we stop thyroxine supplementation by 3 years of age? Like, is there any prerequisite for that? Any thyroid receptor antibody which is crossing and causing?
What
transient?
Anurag mentioned was very important. So that's where your etiological diagnosis may help. If you did not have a etiological diagnosis at the beginning, you have started thyroxine, stop at 3 years of age, repeat and see. If you've done an ultrasound and if you notice a thyroid gland in the normal position with a normal structure, then you can actually consider stopping at 3 years and reassessing. But if you don't notice a thyroid in the normal position and the structure is not right, then you should not stop thyroxine because there is a definitive cause for permanent congenital hypothyroidism.
And I think one other thing which we often get a clue is that suppose during treatment your TSH has gone up. So on follow-up, if your TSH has gone up even once or twice, then it is very unlikely to be transient, because transient we're talking about is mainly 2 to 6 months usually. So that's another point. If your TSH has gone up in between, it's very unlikely to be reversible. On the other hand, if your dose is very low, maybe 2 to 3 microgram per kg per day and TSH has never went up, that is the case. If your ultrasound shows the thyroid, stop and watch for around 4 to 6 weeks and see how it goes.
I would add another point also. In spite of us seeing not much of climbing in the dose during treatment for the first 3 years, very, very rarely we see minor dysharmoniogenesis continuing to be permanent even on low doses of 12.5 or 25, though we never climbed on our doses for the first 3 years.
Anurag, actually, okay, now by 3 years we have confirmed this is a lifelong, the baby has to be, that is the child has to be supplemented on thyroxine. Okay. As a practicing pediatrician, how to follow up this child till the adolescent age group? What all the things we have to do because we are going to do thyroid test once in 6 months. We are going to ask them to repeat and show us what are the other things we should do in our consultation, like height, weight, and what are the other things, essential things we should do in these thyroid children, and how to reinforce them.
Yes, I think that's a very, very important point to discuss. One important thing is that whenever you see a child for congenital hypothyroidism for the first time, you have to assess for few things, especially hearing, because many conditions may have a hearing issue because of hypothyroidism or because of etiology like Pendant syndrome. So a routine hearing evaluation should be done at baseline. A very careful evaluation for cardiac assessment. We don't recommend a routine echo, but you should look at the cardiac because there is a higher possibilities of these people to have a congenital heart disease. So this has to be evaluated. Once you have excluded these two, you have to basically follow very carefully in terms of their development, in terms of their growth, in terms of their pubertal development. Now, 6 months is going to be, I would say, inadequate in terms of follow-up. I will definitely recommend a 3-monthly follow-up. Especially as Dr. Ahila said, first after 2 weeks, then monthly. And once your TSH stabilized, maybe 2 monthly in the first year. And then maybe if everything is fine, 3 monthly, but never less than 3 monthly, because more than 3 monthly, because there a lot of changes with children will happen in these scenarios. So you monitor them as you monitor anybody else for growth, puberty, and development. And if there are any problems, do a early intervention, because many of them, unfortunately, who are not picked up on screening will have developmental delay. They need early stimulation. And hearing is one thing which is not to be missed. I think that's very, very important. Second thing is squint. Often many of these children may have squint, which we have to really look for and follow up as well and manage accordingly.
Yeah, I'm very happy that Anurag mentioned squint. Missed diagnosis and late presentation of severe congenital hypothyroidism invariably present with the squint. And quick, close follow-up and intervention definitely helps them and makes them better in the long run.
So hearing and optal also comes. Okay. Okay.
Thank you, Dr. Anurag. Like moving on to acquired hypothyroidism. Suppose we have an obese child and the TSH comes as 7 or 8. Should we treat those children or can we wait for some time? What is the recent guidelines regarding treatment of hypothyroidism in obese children?
Okay, I'll take that. So I would not treat. This is because of a leptin initiated change in the TSH. If your total T4 and free T4 play an important role in this scenario, If they are fine, only the TSH is slightly high, I would rather repeat the blood test after 2 or 3 months and then look at the results to see if it is evolving into a hypothyroidism. I would definitely not treat. I would like to confirm my diagnosis or be very sure that this child has hypothyroidism before I recommend lifelong thyroxine replacement for anyone. So even if the child is obese, it does not mean, but there are important clues on the growth chart. If the child is short, the child is also not short for the mid-parental height and heavy and also is evolving, you will keep a close watch and look at the blood test and confirm the diagnosis before you give medicine because you're going to prescribe lifelong.
Thank you, madam. So
I think I just like to add one point on that. In our study of around 400 obese children, we found that 35% had a TSH between 4.5 and 10. So this is a very, very big number. And this is the most common referral that we are getting for pediatricians regarding treatment. So this is, as Dr. Ahila nicely said, it is the effect of obesity, not the cause of obesity. And when we followed them up over a period of 1 year, 80% of them normalized. So clearly this is a physiological adaptive response, not needing treatment unless you have goiter, you have short stature, you have got a TPO positivity and all those which will indicate. And even if TSH is less than 10, I'll be very, very wary and they will improve.
Juvenile hypothyroidism, when to suspect? What are the clues to suspect in a school-going child or a toddler?
Anurag.
Anyone can take.
So Dr. Ahila, you want to take?
No, please go ahead, Anurag.
So yeah, so hypothyroidism is something which affects everything from head to toe. So you can start off with, let's say, growth failure, especially if you have a short and plump child. Puberty, you can have early puberty or delayed puberty. You can have problems in terms of mental development, worsening of school performance. You can have severe headache and vomiting because of large TSH producing, causing a pituitary enlargement. You can have myopathy-like features with pseudo-hypertrophy with high CPK levels, which will cause the muscular appearance. Of course, you can have severe forms in the form of coarsening of skin. You may have problems in terms of constipation. Pericardial effusion, I've also seen rarely. Nephrotic syndrome, so hypothyroidism should be suspected pretty much in a large variety of situations. The most common a pediatrician will get would be short stature with obesity, which is a very, very clear-cut finding. Precocious puberty in a girl with delayed bone age, that is the second big marker that you will think of. And the third situation, of course, will be if you have some worsening in terms of school performance, lethargy. These three will be the primary ones. But think of in a wide variety of situations, high cholesterol, high CPK levels, and the list will go on and off. And I would say there's a huge number of lists, but these three will be the most important, I would say.
The same line, suppose I get an adolescent who's tested with the thyroid function test and the TPO comes positive, but the TSH is only slightly elevated and the free T4 is normal. The TPO is positive, suspecting Hashimoto's thyroiditis. Should we go ahead and treat this child?
No.
Or can we follow them up?
TPO only says this child has autoimmune thyroiditis. The thyroid functions are still normal. The TSH is only slightly elevated. The free T4 is normal. You will wait, watch, and repeat the test. And you should have definitive evolving hypothyroidism before you recommend treatment because it will be permanent. Just antibody positive does not mean you start treatment. I've got some children on follow-up for more than almost 10 years. They continue to antibody positive. Once you're positive for life. I never repeat antibodies after the first time. I just looked at the thyroid functions and a clinical review, probably if initially once in 3 months, and if there's not much of change, I do it once in 6 months or so and just watch. Only if there's definite features of hypothyroidism with a drop in T4 or free T4 along with a raising TSH and a TSH of more than 10, then I would treat. And that would be lifelong replacement.
Lifelong treatment. Okay, point well taken.
Madam, which antibody do you prefer, madam? TPO or 8 anti-thyroglobulin? Which antibodies you prefer in usual?
I do both.
I
do both. But because I actually, there are some studies which keep on talking about anti-TPO, but I've seen some children have mostly a significant proportion of anti-TPO positive, but I also have a significant amount of children with only anti-thyroglobulin positive without anti-TPO. So I just repeat both, but it does not alter your treatment. You only look at thyroid functions and treat. If you don't have antibody, don't worry. Just
And
Watch
just
and
to
do
add
that.
one point, that when you say TPO positivity, people say, okay, the normal range is 40, 42 is positive. No, it's not like just a simple thing. Antibodies are actually titers. They may be 10 times, 5 times. So the titer will be very, very high. So marginal TPO, you will ignore. Don't even think that this is positive. And then we say, okay, TSH is 5.2 and TPO is 42. We should treat. So it's not that way. That is a very, very important message also in that.
And here the tricky point is, mainly compared to congenital hypothyroidism, we practitioners should not start with a high dose of thyroxine. So this message mainly, what is the message you advise, particularly when you diagnose a fresh case of juvenile hypothyroidism? What is the dose to start with, how to titrate, and how to follow up these children?
So the general dose, as far as the dose will be like, if you talk about the full replacement doses, 100 microgram per meter square per day. But when you have a very severe long-standing hypothyroidism, start at 25% of the dose. So maybe you start off with by 25 micrograms. Maybe sometimes I've started even at lower dose and gradually build it up. Because if you have a rapid escalation in dose, they will be benign intracranial hypertension. They will do worse in schools. They will complain of headache and so many other problems will happen. Then once you started that and you built it up, you then want to monitor them very carefully for growth. Also monitor them very carefully for bone age. Our studies show that although they are very short to begin with, their bone age is very retarded. But every year of treatment, the bone age in severe prolonged hypothyroidism actually advances by more than 2.5 years. So in 2 years, you may have gained height, but you may have gained bone age by 4 to 5 years. So very rapid advancement of bone age. It's like a spring effect. You had pressed the spring and suddenly you have released it. They will have a rapid bone age enlargement. They will have rapid cubital development. And sometimes if there is a delayed diagnosis, you may actually need to really have, we have used GnRH analog and we are going to publish the data also, that with late diagnosis, if you have very short child and you start treatment, they enter puberty, you may have to think of GnRH analog as well. So monitor growth, puberty, development, start at low dose, monitor TSH, which is the main thing to titrate at, not much role of FT4 in primary hypothyroidism follow-up, maintain TSH 0.4 to 4. I think that will be the pretty much goal from that.
In
Thank you,
terms of
Dr.
milligram per kilogram, in terms of milligram per kilogram, for example, 10 to 15 mics per kg, that is in newborn.
So that's too high. That's
For
too high.
Hashimoto's, what is the
Yes.
dose you say?
Generally, as I said, meter square works well because you have children of different ages.
Okay.
Adult dose is 1.6 microgram per kg per day. In children, I think younger children may require somewhere around 2 to 3. That is a total replacement dose, not the starting dose. And then maybe older children will go around 2, 1.5. But of course, meter square, I would say, will be a much preferable to get a better idea as to what sort of doses. Dr. Ahila?
Yeah, I actually have had two children with convulsions after being put on high doses by their treating pediatrician, and one child with cardiac failure. So I am very, very wary of starting at very high doses of thyroxine replacement, particularly when the TSH is very high. That means it's a long-standing hypothyroidism. The bone age is severely delayed. Again, it's a long-standing hypothyroidism. So in those children, if it is say, if the TSH is say 30 or 40, I wouldn't mind starting off at a maintenance dose at the beginning itself. But in children with long-standing untreated hypothyroidism, I would definitely start at a very low dose and gradually build up to help the child adapt both CNS-wise and CVS-wise. Next, I'm absolutely along with meter squared body surface area. I think we regularly do meter squared body surface area for any hormone treatment, whether it be it hydrocortisone, be it thyroxine. It's so much easier, including fluid replacement in diabetic ketoacidosis. In obese children, meter squared body surface area is very useful. There's one formula, 4W plus 6 by W plus 4W plus 7 by W plus 90. Where you just put the weight on that and you will get the body surface area even if you don't have a proper height. So it is 80 to 120 because your physiological secretion rate is 100 microgram per meter squared per day. I usually keep it at 80 to 120 micrograms per meter squared per day. The first is when you actually look at the meter squared body surface area. Subsequently, your thyroid functions will guide your dosing.
Okay.
And one more point, which Anurag stress, I would like to stress again. Pushing the doses too high, too fast, you will activate the bone age. They will just rush through growth. You will actually compromise on the final height quite a bit if we put too high a dose and too fast.
So the important message for the practitioner is don't be aggressive when you are treating a juvenile hypothyroidism like a congenital hypothyroidism, number one. And sometimes the tricky question is whether it is a late onset congenital hypothyroidism or a juvenile hypothyroidism. Sometimes we are confused how to differentiate, madam. Any specific thing is there to differentiate whether it is a late onset congenital hypothyroidism or a juvenile hypothyroidism, because the treatment is different and we have to be a little aggressive if it is a congenital.
I think out of all these years of practice, I've had only 2 or 3 times when I had this confusion. But if your TSH is very high, and if it is, say, it's usually at around 1.5. My earliest acquired hypothyroidism was at about, I think, 1.5 to 2 years of age. That is a reason. And if you do a nuclear scan, that will show dysharmonogenesis even in acquired hypothyroidism. So it's not going to be very beneficial. So I would actually go with my clinical acumen. I would rather start slow and climb up. But if there is significant compromise in development, I would start high and go down.
So message well conveyed. Congenital hypothyroidism, treat aggressively with higher doses, and juvenile hypothyroidism, use a lower dose and gradually build up. Is there any clinical clues to diagnose central hypothyroidism? And what are the implications in treatment? Should we start them with the thyroxine straight away, or should we do some other tests in case of central hypothyroidism?
Anurag.
Okay, so central hypothyroidism is a rare form, first of all. So both congenital and acquired central hypothyroidism is rare, and usually it is not a isolated phenomena. It's usually a multiple pituitary hormone deficiency. So you will have evidence of other hormone deficiency, and you have features like micropenis, cleft lip, cleft palate, hypoglycemia, neonatal cholestasis. There will be the other features which will be there. The most important biochemical feature would be a low level of free T4 with a TSH level which is less than 20. Anybody whose FT4 is below low, you have TSH more than 100. If your TSH is less than 20, think about central hypothyroidism. And as Dr. Ramanathan said, you have to think of other hormone deficiency like cortisol deficiency in particular. So do a cortisol level, think of a MRI, and only after you have corrected cortisol deficiency should you start thyroxine. Again, the requirement in central is lesser compared to a primary hypothyroidism, and you follow up using FT4 rather than TSH. So key message is, if you have midline defects, if you have micropenis or other features, think of a central hypothyroidism. Do a cortisol and an MRI essentially, and then on follow-up using FT4, use a lower dose compared to a primary one.
I'll just add one more point. If you have nystagmus in the newborn period, you should think of a pituitary insufficiency, and you should watch, because HESX1 mutation, septo-optic dysplasia, is something we frequently miss. So nystagmus in the newborn period is an important clue. Prolonged physiological jaundice in a child with nystagmus, you should watch for pituitary insufficiency. So that and hypoglycemia. These are 3 important signs, because they will be suggesting growth hormone deficiency, hypothyroidism, and cortisol deficiency. So as Anurag mentioned, you should correct cortisol before you start thyroxine. The next point is, in a sick child who's admitted in the NICU, if you have a low TSH and a low free T4, that may be a sick euthyroid syndrome, and you may be mistakenly considering a central hypothyroidism. So be very, very careful. It should be a stable child when you're looking at central hypothyroidism.
Isolated central hypothyroidism, how commonly you have seen, Akhila?
I've seen quite a few.
Right.
Okay, one more point actually. I just had a patient from the US. So the way you measure TSH is also important. So in the newborn thyroid screening, when they get a very low value of 0.04, they think of central hypothyroidism. But the way you measure the hormones are a little bit different in 2 ways they can measure, and that may miss one type of TSH. So you should actually have the full profile before you diagnose a central hypothyroidism.
Thank you, madam. Dr. Palaniram, can we move ahead with the presentation?
Last question in the thyroid. Thyroid swelling, that is a patient presenting school age or any age, presenting with a goiter, diffuse soft goiter, diffuse firm goiter, diffuse nodular goiter. What's your basic approach with respect to the goiter in the age group? This is the last question with respect to thyroid.
Shall I take that number?
Yes, Dr.
Yeah.
Please.
So if it is a uniform goiter, maybe it may be soft, it may be firm, I would definitely do an ultrasound. If the ultrasound shows a uniform enlargement of the thyroid, I would not worry about it. I would go ahead and treat the hypothyroidism and keep a watch on the thyroid. But if you have a swelling, which is, it's in one area, if you have a thyroid nodule, that is something which I will place huge importance on. That definitely needs complete evaluation, because I've had quite a few papillary carcinoma of thyroid in very young children, follicular carcinoma. I had medullary carcinoma of the thyroid. So any isolated thyroid nodule, in ultrasound, if you have an expert sonologist, they can pick up a lot of changes which can suggest malignancy. Even otherwise, if it is a thyroid nodule, you will need the full workup and you cannot miss them. But if it's a uniform thyroid swelling, I don't think there's much to worry about. But you will do a thyroid function and then treat them based on the thyroid function and keep a watch on the child.
So message is loud and clear. Nodular goiter, don't delay referral. It has to be referred as early as possible for further evaluation. Rams, you can further next go
Yeah,
for the next.
we'll proceed with the growth chart, sir.
Growth chart. Yeah.
Okay.
So growth chart assessment is a fundamental tool and to evaluate any child with growth failure. Unfortunately, as pediatricians, we are not, most of us are not plotting the growth chart or not interpreting in a proper way. So if growth is plotted in a growth chart and it is evaluated, like most of the diagnosis, we can get most of the diagnosis before ordering any tests. So I request Dr. Anurag to go ahead with this presentation of growth charts.
Thanks a lot, Dr. Ramanathan. And we will just try to see why growth chart is important. So we had this 12-year-old girl who was referred to us with a height of 120 centimeters and weight of 15 kgs. And you can see the growth chart, which is plotted out here with regards to the height and weight. And the parental height was somewhere around the 10th percentile in that regards. Now, the basic evaluation was done, which showed a hemoglobin which was mildly low. TSH, TTG, and other basic workup was normal. They had evaluated further for IGF-1, which was found to be low, and basal growth hormone was found to be very, very low. And at that point of time, they had referred the child to us for quote-unquote growth hormone deficiency. Now, if we really look at the growth chart, what we are seeing clearly is that the height was much less affected as compared to the weight. And this clearly is a short and lean child, suggesting a nutritional cause as against a short and plump child, which indicates an endocrine cause. So clearly, if we had evaluated the growth chart properly, we would not have thought of a possibility of growth hormone deficiency here. And we know that IGF-1 is unreliable in nutritional scenarios, and growth hormone, basal growth hormone, has no role. So if a proper chart evaluation was done in this case, we would not have went into this diagnostic dilemma in that regards. And in this scenario, it turned out to be, as I'll discuss later, a celiac disease which was missed in because of a IgA deficiency. So growth chart evaluation is pivotal as far as that. And we'll talk about how we should do a growth chart evaluation and also touch base upon how technology can help out in achieving that. So 12-year-old girl, height of 132 centimeters and weight of 20 kgs. We know that short stature is common. Around 2.5% of all children, most of them are physiological and 10% have a pathology. The aim of a pediatrician is not to unnecessarily investigate these 80% while not missing these 10%, and that becomes very, very redundant in that regards. Now, as I said, growth failure mostly is physiological, constitutional delay of puberty and growth, which is characterized by somebody who is short for the population but normal for the bone age. Familiar short stature who is normal for the family. Somebody who is short for the population, for the bone age, and the family will be pathological, which could be because of a skeletal problem, which is primary, and secondary, wherein we have a nutritional or an endocrine cause. So the key question which we have to answer as a pediatrician in a child with short stature is it really short stature? If it is short stature, is it physiological or pathological? Is it primary or secondary? And finally, nutritional or endocrine. Now, how do you identify the need and criteria for evaluation? So we have done a very good study which clearly shows that if your height standard deviation score is going below -2, the chance of pathology increases to 45%, and below -3, it is like 80%. So anybody who is above -2 standard deviation score, you don't need to really worry. If it's -2 to -3, you need to evaluate, and less than -3 definitely requires an urgent evaluation. And which chart to follow? I think that a question has been answered very well. Our study has already shown also that compared to the other charts, particularly the WHO and the CDC chart, the IAP 2015 charts are much better in terms of identifying short stature. So if you have a child who is very, very short, much below the percentile line, somebody who is short and not growing, that is height is below and the growth velocity is less than 25th percentile. And finally, somebody who is not growing at all. These are the three indications where you need to evaluate. So somebody who is below the first centile or -3 standard deviation score, -2 to -3 and not growing at all, and somebody who has crossed 2 or more percentile lines between the age of 2 and puberty requires evaluation. Once you know that, the next question is it pathological? And to answer that, we have got three things. Look at growth chart, puberty, and bone age. And that's why when Dr. Palani asked me as to what are the things which a pediatrician should have, so a careful growth, puberty, and if possible, bone age will give you a diagnosis in that regards. So when you're assessing a growth chart, you're looking at the absolute status of the child. You can compare it using percentile or a height standard deviation score, which is a more objective measure. You can also have to then compare it whether the child is short for the family or not. And for that, you have to calculate the target height, which is mother's height plus father's height divided by 2. Add 6.5 centimeters for boys and subtract 6.5 centimeters for girls. And then you can calculate a target height standard deviation score. If a child is within the plus minus 1.5 standard deviation score, or roughly 10 centimeters, from there you can say that, okay, this child is a familial case. Otherwise, you will say this is more likely to be a non-familial cause of short stature. The third big thing is nutritional versus endocrine. I said nutritional children are lean and short, endocrine are short and plump. So here you look at the height, age, and the weight age. If the height, age, and weight age both are affected, this is nutritional. If the height age is more affected, this is endocrine. And we have seen in our study that BMI standard deviation score is a good surrogate as far as the nutritional cause of growth retardation is concerned. So now we have a 12-year-old girl whose height and weight are here. So how do we use growth chart? There are three questions you have to answer. Is the child short for the population? The answer here is yes, the child is below the 3rd percentile. The next question is the child short for the family? So you calculate the MPH and then you have +6, -6, and then do line parallel to that, and you will see that this child, though looks short for the population, is not really short for the family. So this looks like a familiar short stature. And then you look at the nutritional component, you do a height age, which is the age at which the current height becomes the 50th percentile. So in this case, you draw a line till 50th percentile, go down for height as well as weight, which again is 9 years. So clearly this girl looks like a familial short stature. If she is prepubertal, she has a delayed bone age. Best to follow up in this regards, don't worry. Second important thing, of course, is the pubertal assessment. And we have discussed that the most important part in girls to look at is the breast elevation. If you have B2, from here you expect a 20 centimeter increase in growth. Remember that obese girls are more likely to be identified as B2 because of the lipomastia. So all you need to do is to approximate your thumb and finger. If there is resistance, then only you think that this is B2. From here, your next point is B4, which is a secondary mount from where you have around 10 centimeters to grow. And if somebody develops menarche, you only have 5 to 8 centimeters to grow. So if you have a girl who is 135 at the start of B2, you expect 155 centimeters as the final height. B4, 145, and menarche, only 140. So you have to be very, very careful in interpreting the height in terms of puberty, which becomes important in that regards. In boys, look at testicular volume, and testicular volume of 4 ml means that puberty has started. Volume of 10 ml means that the growth spurt is there. But if you are at 15 and 20, you have got very, very limited time to grow in that regards. Coming back to growth chart, 13-year-old boy, and we see the height and weight. This child is short for the population and short for the family as well. Now, if you look at the bone age, and this is a very important issue, and bone age is going to decide a lot of other factors. So when this bone age was sent, it was reported as 14 years. Now, this really means that there is a panic, there's something needs to be done, and this child was advised growth hormone treatment. But when the child came to us, we looked at puberty, he had delayed puberty, we reassessed bone age, it was found to be 10.5 years. So clearly, the whole diagnosis changed and the whole perspective changed. So when you're looking at growth chart, look at growth chart, look at puberty, and look at bone age. These three go hand to hand to give you the right diagnosis. But unfortunately, reliable estimates of bone age are not available, and that can be very, very crucial. There are methods which are available like GP Atlas and Tanner Whitehouse, but they are cumbersome for routine pediatricians to do. And then there are automated methods which are very expensive, like Bone Expert costing you around 700, 800 rupees per X-ray. So what we need is a simple, accessible tool which validates against the standard method and gives us a quick tool in that perspective. And what we did was that we developed a bone age application which just focuses on 5 key sites in terms of bone age. All the pediatrician has to do is to compare the 5 sites, which is middle finger in the middle phalanx, proximal finger in the proximal phalanx, thumb, radius, and ulna, and that really gives us a clear idea as to what really the bone age is. So based upon this method, which takes approximately 1.5 to 2 minutes, in total, we have developed and we have validated this and published this data and has shown clearly that this is validated against gold standard, gives you a very narrow range with a high level of accuracy. There's a simple method which is available, which you can use immediately to get your bone age from that perspective, which is very important. We are working also on AI-based bone age estimation, and hopefully that will be much easier to just upload the X-ray, you get the immediate result quickly on that regards. So as I said, growth chart, puberty, and bone age will tell you whether it is physiological or pathological. If it is pathological, look at parameters basically like facies, look at body proportion to identify these rarer causes, but they are easy to identify, syndromic and dysmorphism. And then finally, for nutrition versus endocrine, all you have to look at is go back to the growth chart. If you have a child who has a predominant effect with regards to the weight compared to the height, this is a nutritional cause. On the other hand, if you have a child whose height is much more affected compared to the weight, you are dealing with an endocrine cause. And as I said, BMI standard deviation score below -1 suggests a nutritional cause. So just to summarize the approach what I discussed, the first issue is the child short? Yes, if it's above -2, don't worry. Below -2, look for corrected height standard deviation score. If it's above 1.5, it means it's a familial cause, don't worry. Then if it's not below 1.5, look for the height SDS for bone age. If that is also above -2, this is CDGP. So these three will take 90% of your cases who come to you with short stature. Either they are not short, or they are not short for the family, or not short for the bone age. So this is something which is important. Only after you start screening for the routine test, you do CBC, ALT, creatinine, electrolytes, CTG, definitely in northern part, because celiac is very common, thyroid and blood gas. If they are abnormal, of course, you make the diagnosis. Otherwise, wait for 6 months. And only if the child is not growing, then you should go ahead with evaluation for second line tests like karyotype in all girls whose routine evaluation is normal. And only after that, you do a growth hormone stimulation test. So the message is that reevaluation is required only for 10% of cases. If you use this approach, which we have validated, we have found that it will cut down the cost in terms of evaluation. And this is something which is very helpful for resource poor countries in that perspective. So if we go back to this case, whom we discussed earlier, a girl who was referred to us with query growth hormone deficiency, but clearly we see here that this is a nutritional pattern. And when we did further evaluation, we found that this was actually a celiac disease. So these diagnostic inaccuracies, so to speak, in terms of growth evaluation are not uncommon. So we actually did a multi-center study in which we gave 250 cases with details about clinical parameters along with the bone age X-ray and asked the pediatricians, the pediatric trainees, and pediatricians who are senior and junior to really comment about what is their likely diagnosis. And when we compared that with regards to the gold standard, we found significant discrepancy in terms of missing of pathology, in terms of overdiagnosing. So over workup was required and there was misclassification. So it's very, very common, and we need to have a rational tool which we should allow immediate evaluation in that regards. So we have already developed a mobile application which really provides immediate interpretation, and it has been found to be highly concordant with clinical diagnosis. This is a tool available and it's been shown earlier to be quite effective. So if we go to this case, 12-year-old girl, height is 120, weight is 15 kg. We already discussed about this case. And this really, if we had done the interpretation, we would know immediately that this is nutritional pattern. We do not need to do any further evaluation in terms of growth hormone right away to begin with. That becomes important. And this case, clearly, as we discussed, is a familiar short stature case. And if we feed in the basic data, we would get the information that this is more likely to be a familiar short stature based upon these inputs. So if you really either use the growth chart properly, or there are tools which are available, they will give you the likely diagnosis in that perspective. And if you go by this child whom we discussed already about the possibility of growth hormone deficiency versus a scenario of CDGP, if we interpret the data properly, we know that this case is not likely to be GHD. This is constitutional delay of puberty and growth. You have delayed puberty, you have delayed bone age. Better to wait and watch. So before you do too many investigations, look at the chart, and there are tools available which can help you out to identify that in that regards. Another interesting case, 8-year-old boy, height is 100 centimeters and weight is 18 kgs, and the workup showed a elevated TTG. So a diagnosis of celiac disease was made. Now, if you look at this growth chart, what you're seeing is that what is more affected is height as compared to the weight. So clearly this has been labeled as celiac, given a gluten-free diet, and there is no response at all in that perspective. But when the child came to us, we said, okay, this is not nutritional, this is an endocrine cause. You should do evaluation. We did a growth hormone, which was very, very low. And if we really analyze the data based upon all the parameters, and we see clearly that the BMI SDS is pretty positive. It is a short and plump child. This is an endocrine cause of growth retardation. So look at the data before you really suggest any particular workup in that regards. So based upon all these problems and findings, we have already developed a bone age assisted interpretation of growth, which based upon the anthropometry, pubertal status, and the bone age, which can be assessed immediately, gives a right diagnosis as well as guidance about what workup should be done, along with tracking and what is required from that perspective. So this is going to help out in terms of evaluation. And what has been shown is that that improves the concordance scores by 96%. So we need to have a point of care tools which allows every pediatrician to have immediate access to a lot of information, and that information can be interpreted, and then they can use that for making the right diagnosis in that regards. And that really is something which we want to go ahead on that regards. So just to end, all of you can go and have a look at our website, learning.growsociety.in, which has got multiple resources regarding pediatric endocrinology, as well as various courses and mobile applications that we offer. So at the end, I'd like to just summarize that growth chart, bone age, and puberty are pivotal for any child who comes to you with growth, puberty, or endocrine disorders. Unless we do it properly, we will not reach the right diagnosis. Use the tools which are available, and there are now easy tools for bone age assessment, for pubertal assessment, which can be used to get the right diagnosis. Thank you.
And that was a wonderful presentation, Dr. Anurag, in a limited time. So you have re-emphasized the need for proper anthropometry and growth chart plotting. And as Dr. Anurag said, there are numerous lectures and mobile applications are available in the Medi Classes platform. So those who are interested can go and look into that. Dr. Palniram.
Yeah, as Dr. Anurag told, it can't be overstressed again, the importance of the growth chart in day-to-day practice. Start taking the height and start measuring the height and plotting the growth. That is very, very important. Without a growth chart, if the patient goes out of your chamber, it's a criminal crime on the basis of on the part of a pediatrician. That is what the Professor Amdekar used to say again and again. Number two, whenever the weight is affected more than the height, you think in terms of mostly a chronic infection or chronic organ dysfunction, as Professor Amdekar says. And whenever the height is more affected than the weight, always think about the endocrine causes, which he has already told. So with the growth chart alone, around 6 to 7 diagnoses can be easily made. Now, the very important question I want to ask is like a catch-up growth for preterm babies as well as the SGA babies. Actually, for example, a newborn of a infant of a diabetic mother, will be having actually 3.5 kg or something. By 1 month, the baby will reduce the weight and comes to around 3 kg. That is, catch down happens in this, particularly in the neonatal period itself. Like that, the catch down growth, particularly we come across plenty of babies not growing, but they are very active and healthy. So this is the problem with respect to the parents asking the pediatricians why my baby is not putting on weight and not growing, actually reasonably growing, but not putting on weight. This catch down growth phenomena is a very important phenomenon. Can you explain, Dr. Anurag?
I think that's a very, very important point. And one thing to remember very importantly here is that when we're talking about growth, particularly in the first 2 years of life, we need to interpret in terms of the parental expectations and the other factors as well. So the size at birth is determined by the environment. and size at final height is determined by genetics. And the switch between environment and genetics typically happens by around 2 years of age. So in the first 2 years of age, you can have an appropriate catch down or a catch-up growth, which can happen, and this has to be interpreted. So if you have somebody who was born to an infant of diabetic mother and was born large, it is natural for that child to become less because they will going to go towards the family. If you are born SGA to a tall parent because of PIH, maybe you will gain more in that perspective. So this is a normal phenomena. But the second important factor, as you said, is there that the weight is not increasing. The parents are very, very concerned about that. This is a common thing. Often this concern is more because of parental anxiety rather than a real factor. So if you demonstrate on the growth chart that this child is pretty much in the normal range, we do not need to do that many evaluation. That usually suffices. However, if there is a very, very significant fall, we do have to consider possibilities of pathologies and very early onset growth failure. Of course, a few things which we can think of is definitely renal tubular acidosis is one thing which I have seen reasonably early in terms of the growth, and of course various defects in terms of the aldosterone effect. So your sodium, potassium, electrolyte, those becomes important. But 95 to 99% of these cases would mainly be nutritional. So how do they are getting the feeds and other factors become important, and many may be actually normal and they are labeled as not growing well.
One more question to Dr. Anurag. Yeah.
On the same note, like SGA babies, usually they take time to catch up. They take up to 3 to 4 years to catch up. So how long we can wait for a reasonable catch up, or when we should refer to an endocrinologist for further, particularly now the growth hormone therapy is available for extremely SGA babies. So we should not feel because you should have doctor, you should have referred before itself, because this is the guilt feeling we should not have.
Can I answer that question?
Yes, Aguila.
So
Okay.
both happens, madam. One point, there are some SGA babies who are slow to catch up, and we have seen babies who rapidly catch up also. Like, is there any clinical implication in those kind of children? Like they become overweight and obese by 2 or 3 years of age. Those who are born SGA.
Okay. So SGA is defined in various perspectives. So birth length plays an extremely important role. If you measure birth length, that gives you an important clue. The length at birth determines the long-term growth even more than the weight. Though less than -2 standard deviations has become the norm as recommended by international societies. 80% of children who are born SGA will catch up by 6 months. 85% will catch up by 12 months. It's very, very rare for SGA babies to catch up beyond that. That 15% is there. So in case you see an SGA baby who's not catching up on length, that is more important. I will not worry too much about the weight. It is the length that you will have to monitor. If an SGA baby does not catch up on its length by 12 months, you have to keep a close watch on them. And sometimes we start treatment as early as even 3 to 4 years of age.
Thank you. Thank you. Wonderful.
Just to add one point, there's a recent guideline from the IMP, the International Society, which say that if your height SDS is below -2.5 at 2 years and -2 at 4 years. So we always say 2 to 4 years, but there is now more clarity which is coming from IMP. They say if it's below -2.5 at 2 and -2 at 4, these are the time that you should refer to a specialist. So this is directly coming from the guidelines, just to add that.
So is there a chance of these children going in for metabolic complications, small for gestational age babies, though those who have a rapid catch-up growth and become obese?
So the metabolic sequelae are different from the growth. They may or may not go together. So that is why we don't concentrate on weight. We look at length. If the length is good, if the child is growing reasonably well, also have to remember that the children's growth and development stages are different. At 10 months of age, the child is completely playful, not interested in eating, is going to run around, to take one mouthful, and the mother is worried because she's a well-educated mother. She wants to give that 2 idlis which she has planned for that morning. Unless the child eats, she's not going to be satisfied. So it's different in what the child requires and what the mother wants. So that conflict actually, I would actually concentrate only on the length. Weight, if you push too much and try to gain, you are actually going to, the weight at 2 years of age will also determine some of your metabolic sequelae in late life. So there are some modifiable risk factors and some unmodifiable risk factors. Being born small for gestational age is not modifiable by us. But having a good lifestyle is modifiable by us. So you can stop your metabolic sequelae by introducing a good lifestyle into the child.
Just to add a point, what Dr. Ahira was continuing is that always give example that this SGA is a typical Sita Gita story. It's like twins. Some of them will have a very rapid catch up and they will have metabolic complications, while some of them are destined to be short because they are not catching up. So while we are looking at definitely ensuring that they have enough nutrition, we don't want them to push towards the other side. And often we see that in families, they are being pushed that they eat more and they will go in weight. So both ways, so there is a way we have to go. Somebody who is born SGA should be in the normal range, not too much, not too less. That is the key message, I think.
Aguila, as you told, the asymmetrical IUGR babies catch up with respect to height, like this, what you have told, by 80% by 6 months and other things. But a symmetrical IUGR, usually they don't catch up like this. Then what to do?
No, you monitor. Long-term growth charts are the most important ones. If you're going to look at growth velocity over a period of time, it will tell you. That is why, as Anurag said, 3 to 4 years is something which we keep as a cutoff. And beyond 4 years, you're not going to wait because you will lose precious time. You will have lesser time for intervention, because when you introduce your growth hormone, not only improves their growth, it also has a lot of significant metabolic benefits in children born SGA. So we actually use growth hormone not only for height, it also for metabolic criteria. So monitoring long-term growth on a growth chart is extremely important compared to a one-off height or a weight.
Okay. Thank you. That's about the SGA things, which we have now clearly have. Mainly the height monitoring is very important, and other things we have clearly known. Now, in continuation with this growth, failure to thrive, what are the common endocrine causes we should think of? Because in the early infancy or mid-infancy, we come across failure to thrive with endocrine causes. What are the endocrine causes? Because the endocrine causes are not obvious. For example, congenital heart disease is obvious. Recurrent respiratory infection, respiratory causes are obvious. Syndromic causes are obvious. But whereas endocrine causes are not obvious as a cause of failure to thrive. What are the causes you should rule out whenever you come across a failure to thrive in an infant?
Anurag.
Okay, so I would say if we talk about an infant in particular, we have to focus on 3 major things. First of all is, I would say, RTA, which is not really an endocrine cause, but I will definitely do a blood gas because it will pick up RTA as well as metabolic alkalosis. If you have metabolic alkalosis, then you're going towards a different group of disorders like Bartter syndrome, Gentleman syndrome, rare disorders of aldosterone excess. So blood gas is very important. Electrolytes is absolutely important. So if you have hyponatremia and hyperkalemia, you have quote unquote aldosterone impaired effect, which would mean starting right from an adrenal insufficiency to a CAH, which is a milder form. You may also have a aldosterone deficiency or a pseudo hypoaldosteronism. All of them will come into that picture. If you have hypernatremia, if your sodium is high, then this could be a nephrogenic DI. A classical presentation, 6-month-old male who comes to you with recurrent dehydration and fever will have hypernatremia, and this will be NDI because of an X-linked defect in the vasopressin receptor. Then if you look at a scenario in which you have hypokalemic alkalosis, I already said, if you have high blood pressure, you're dealing with aldosterone excess in the sense of apparent mineralocorticoid excess, Liddle syndrome, or very rarely hyperaldosteronism. If your blood pressure is normal, you're thinking of Barter's and Gentleman syndrome. You do a urinary calcium and you can classify. So rather than saying that what are the causes, I would say what you should look at is sodium, potassium, and blood gas. 90% of your cases will be picked up. Of course, thyroid, growth hormone deficiency are less likely causes at this age group, but you have to always think of hypothyroidism if you have other features in that perspective. I would say this will be the most common, and of course, rarer ones will be infantile diabetes. You have to always get blood sugar done in that scenario. That is also something which is important. So if you do basic workup like RBS, sodium, potassium, blood gas, you will get your clue and diagnosis there.
So it is very clear the hidden causes are mainly the renal tubular acidosis as well as the adrenal causes are very hidden causes. Sometimes I have faced in my one or two cases of congenital hypothyroidism presenting as a failure to thrive. I have 3 cases of congenital growth hormone deficiency presenting as a failure to thrive. So you can have simple TSH, and that is mainly thyroid function is very important even in failure to thrive cases. Sometimes have a back of the mind growth hormone cases and the renal tubular acidosis and adrenal disorder. These are the 4 to 5 things whenever you come across failure to thrive, when there are no obvious cause we should have in mind. Rams, next you can go ahead, Rams.
Can we move to the next presentation, sir? by Dr. Ahila Ayav.
Yeah.
So now I request
Or,
Dr.
we,
Ahila Ayav.
or we'll finish the questions by another 10 minutes, and lastly we can get the presentation.
Whichever we decide. Okay, then. Okay.
Okay. You start with the next further questions.
Shall we move to the next disorders of
mainly premature thelarche, premature adrenarche, which is very common. We come across in practice. Mainly 2-year-old coming with a thelarche, and SGA babies coming with the adrenarche. What to do, Agila?
So if you have breast development, which is noted before 6 months of age, you will still keep in your mind mini puberty of the young. Sometimes in very, very early infancy, probably because of the maternal hormones. Just beyond that will be mini puberty of the young. But most important thing you have to remember is if there is breast enlargement and it is progressive, this needs evaluation. If there is breast development and it is static and there's no progression, there may be a less sinister cause and you can watch these children. So I would actually look at breast development in the sense of progression. If it is growing, if it is progressing, and the mother is worried, that is an indication for evaluation for breast enlargement, for premature thelarche. Premature adrenarche in children born SGA, in children born to mothers with PCOS, in children born with adrenal basics, you can have premature adrenarche. Remember, thelarche and your uterine development go together. Adrenarche may be in consonance or not in consonance with the progression of true puberty. So you can have adrenarche even without true puberty. If you have mild adrenarche in a young child, say about 5 or 6 years of age, the child is otherwise well, everything else is fine. The child does not have breast development. This is just isolated premature adrenarche. Again, I would go back to modifiable risk factors and unmodifiable risk factors. These children are at risk for polycystic ovarian disease in later life. You can initiate lifestyle measures to stop them from progressing on to PCOS in later life. So is that all you want, or do you want me to talk about sinister type? That's simple things.
Yes. Pubertal gynecomastia is very common in boys. When to worry?
Okay.
So, shall I, Dr.
Yeah, please go ahead.
So, gynecomastia is a very common physiological phenomena. 30% and more boys will have this gynecomastia. We need to worry if it is prepubertal, you don't have a testicular enlargement and you have a gynecomastia, or a post-pubertal. You have had your puberty and then your gynecomastia happens. The reason is that gynecomastia happens because of a disconnect between adrenarche and gonadarche. When you are having puberty in boys, the adrenarche happens first, gonadarche happens later. The adrenal androgens are more likely to be converted to estrogen compared to the testicular androgens. So that's why this gap causes gynecomastia. If, however, your testis is functioning, this gynecomastia goes off. So if you have a gynecomastia before testicular volume of 4 ml, if it's happening after a testicular volume of 15 ml, if it's persisting beyond 2 to 3 years, beyond typically 16 years, or if it's very large, more than 4 centimeters in diameter, that's when I would be worrying about. Otherwise, I would say this is a physiological one, nothing to be done. And often obesity is another factor which we have to work out, and that will help out in that regards.
So usually the message is usually a normal adolescent will have this pubertal gynecomastia, which usually lasts for 2 to 3 years, which we have to counsel the parents. Rams can go ahead.
Any role of tamoxifen in the treatment of gynecomastia in males?
Not really, but if you have a pathological gynecomastia which is persisting beyond 2 years and which is not fibrosed, so very important that you need to have breast tenderness, which means there is an active estrogenization happening. If suppose there is fibrosis, then only surgery is going to help out in that regards. So we don't use tamoxifen often, but in rarer cases of a large gynecomastia beyond 2 years, and if there is active estrogenization happening, there is a role of tamoxifen. But again, it's a very controversial area in that regard. Dr. Ahila, your experience?
Okay, so I wrote the chapter for you for IJP, which you had asked me to do. Yeah. So you palpate, ask the child to put the hands above the head, palpate from above, bring both your fingers from the periphery towards the center, palpate. If you get more than 2 centimeters, that is significant. If it extends beyond the areolar bud, then it is even more significant. If it hangs down near the inframammary fold, that is very significant. As Anurag mentioned, Up to 6 months of from the start of gynecomastia, they'll have tenderness. It indicates that's active replication and hyperplasia happening. Beyond that, when the pain stops, it means fibrosis has started. Usually no medication will help and only surgery will help. Tamoxifen I use only in one scenario where you have a breast enlargement along with short stature. You have a familial short stature, I use it. It is a dual treatment for two conditions in single hit. So I use it to reduce the gynecomastia and also get some final height, a little bit more height than what they destined to. In a tall boy, I would not interfere with tamoxifen.
One more question regarding premature Tilaki. We do have a lot of toddlers and young infants with labial fusion. And many of our pediatricians prescribe this estrogen cream Avalon for that. Is there anything like, can it be a cause for this premature Tilaki? Does it get absorbed or something like that? This estrogen cream which is used for labial fusion.
Once I've seen one patient for whom it was given by Ravi Kumar sir showed me that patient. So the ointment was, their family was asked to apply for 1 month. They just kept applying for 2 years. So this child had premature Tilaki. And you should remember, when you have huge amount of sex steroids floating in the circulation, it can actually trigger true central precocious puberty also. So it has to be very, very wary of prescribing with specific explanation to the family on how much they're going to use and do they really want to. Unless there is a problem because of the adherent labia, I think you can leave it alone and wait and intervene later.
So generally, I just have a lot of cases because Yuthika is practicing pediatric gynecology, and their recommendations clearly are that, as Dr. Ahila said, unless there is retention of urine or recurrent UTI, do not treat. If you give estrogen, it may improve temporarily and then it will fuse again. So it's not going to help you out. As the puberty happens, automatically this problem improves. So again, I am very, I've seen so many cases, as you mentioned, Dr. Ahila, of real puberty triggering from that if they are applying it for a long time.
Ramanathan will go for rapid fire mode. Another 10 minutes only for the thing questions. And endocrine emergencies, what a practitioner should be aware of. Anurag.
Okay, so I think that's a big topic. So I think the key thing is that I'll divide it into DKA. You want DKA as well?
Yeah, but mainly enumeration that we should be able to pick it up in the practice.
So definitely DKA should be considered in anybody who has got unexplained dehydration with polyuria, unexplained encephalopathy, who has also got abdominal pain. These are the common situations in terms of DKA. The key parameters is anybody whom we are diagnosing diabetes, check for ketones. They may have DKA and you may miss it. Start insulin immediately. If you talk about DKA management, the 3 key mantras is go slow. Do not give too much fluid, do not give too high dose of insulin, and do not push in terms of interventions like soda bicarbonate or intubation. All you need to do is to do gradual, correct it over 48 to 72 hours, use low dose of insulin, low amount of fluids, and you will improve over time. Now, about other endocrine emergencies, the most common one would probably be hypoglycemia. And of course, hypoglycemia is most common in the neonatal period. Use age-specific cutoffs for hypoglycemia. Use dextrose only when you have a significant hypoglycemia, which is significant and which is symptomatic. In the first 48 hours, however, if you have symptomatic hypoglycemia, correct it at least till 48 hours because that's a transition phase, and then you start trying to tapering it. If it's persisting beyond 48 hours, you should think of possible etiological workup in that regards. The other scenario which is common is hypocalcemia, very commonly seen. If you have vitamin D related hypocalcemia, you give them calcium. Injectable calcium is very, very important. And remember, you need to give it for at least 48 hours. Do not rush in that regards. Start off with calcium, give it as an infusion for 48 hours. Start calcitriol for 3 to 4 days, and you will have a quick response. Many times, if you do not give them calcitriol, if you do not give 48 hours treatment, they will again have rebound hypocalcemia in that perspective, and that becomes very, very important in that settings. If you have chronic disorders like hypoparathyroidism or pseudohypoparathyroidism, this really will be a big problem because in that case, their stores are totally depleted. You may need a very high dose of calcium for a few days to get it there. So it's not an easy thing, and you have to give oral as well as IV and a very high dose. Of course, anybody with hypocalcemia which is persisting, think of magnesium deficiency in that regards. So I think these will be the three most common endocrine emergency. The other, of course, is adrenal insufficiency. If you identify them, give them a lot of fluids, give them steroids right away, 50 milligram per meter square stat and then 100 milligram per meter square per day, and check for hyponatremia, hyperkalemia. I think these will be the most important ones from that regards. Dr. Ahila, anything to add on that?
No, I'm fine with that. I think I covered everything.
To
I
conclude,
still remember talking to Anurag for one of
let-
my pseudo hypoparathyroidism type 1B. It took me almost 3 weeks to replenish the stores and reach calcium of 6. IV calcium, we had to continue it through a central line, I think, for almost 3 to 4 weeks before we could achieve new calcium.
a patient with congenital adrenal hyperplasia or adrenal insufficiency, when they come with the sickness, how much we should give the sick dose of how much replacement with respect to hydrocortisone or prednisolone we should give in these patients?
In children under the age of 1 year, or say under the age of 6 months, give 25 milligram IV stat and then make it 100 milligram per meter squared per day divided into 4 to 6 doses. If it is more than 6 months, you can make it 50 milligram IV or IM stat and then give the 100 milligram per meter squared per day. In more than 2 years, or about, I would say 3 or 4 years of age, I would say 100 milligram IM or IV stat and then maintenance doses. But in patients with severe unresponsive shock, I have started hydrocortisone infusion to get the pressures up. Meanwhile, you should look at the glucose also. You keep a close watch on the glucose because hypoglycemia is something that will also make them more sick.
So,
Palniraman, can I have one doubt?
Okay, sir.
Yes, you mentioned about the endocrine emergency. This is in a neonatal period. Sometimes during the severe sepsis, you do have the adrenal hemorrhage and leading on to adrenal crisis. That is the most important. I come across few times in a neonatal period, endocrine emergency. Thank you.
Even in adrenal hemorrhage, we'll have to check whether they're actually adrenal failure. Hemorrhage may be okay, but still they may be producing enough adrenal hormones. You may not need to do cortisol replacement unless it's absolutely necessary. So we'll have to evaluate and then decide.
So the message for practitioners, particularly when they are dealing with adrenal patients, insufficiency or CAH, or multiple pituitary hormone deficiency, always try to supplement with the, particularly when they are coming to in a sickness, try to supplement with the minimal amount of what the dosage suggested by Dr. Aguila, mainly hydrocortisone. Try to, this is a very important thing.
And glucose.
And glucose. And the same way, another question is, what is the sick day management in diabetes mellitus patients? What the practitioner should advise? Sick day management tips.
So I think I'll go by 3 things. First, never stop insulin. Second, check blood sugars every 4 to 6 hourly. Ensure that there is enough fluid, there is enough paracetamol, temperature does not rise. Then your doses of insulin depends upon your sugar levels. If your sugar levels are high, which are most common, you have to give extra 10 to 15% of extra total daily dose of insulin that is there. If, however, the child is having abdominal pain, vomiting, and ketone levels, if you check urine ketones, they are strongly positive, or if blood ketones is more than 3, they need to rush to the hospital. The key message is check at least urine ketones and blood sugars. If your levels are high, give extra dose of insulin. The child is not improving, rush to the hospital, because this is the major sign of decay which may be there.
So this is regarding a question regarding sampling. So there are some labile hormones like PTH and insulin. Is there any specific way that the sample should be collected or how it should be transported to the lab? Especially parathormone and insulin. Dr. Anurag, please.
Okay, so these hormones are very, very labile ones. If you allow them to be in the room temperature, they will get degraded. So best is to put them, process them immediately, or put them on ice so that they are traveled and transported appropriately. PTH is the most problematic, and often we will get reports which are really haywire. So we say, okay, you go to the lab and give the sample there, rather than collection center. Now everywhere they take it, and they will always give you reports which are falsely low.
So in a child with constitutional obesity, in spite of lifestyle modification, some of them don't improve. Like, is there any role for metformin in treating those children?
Metformin does not help, but there are a lot of new drugs which are coming up, including GLP-1 analogs. I'm quite happy, but not in ordinary obesity. I would say morbid obesity. Otherwise, only lifestyle measures. In children, Under the age of 12, no intervention except diet and exercise. Beyond 12, now GLP-1 analogs are approved. I haven't found much of use with Orlistat or the Oglibos or any of them. GLP-1 analogs for morbid obesity, like 167 kgs, I have a child, so I've just started on GLP-1 analogs. So children like that, we do use medication. And then in severe obesity, class 3 obesity with associated comorbidities like hypertension or obstructive sleep apnea, and it's not responded to any intervention, the child is depressed and there's no progression, I think that is a situation for bariatric surgery.
Yeah,
Dr.
just to
Ahila,
add, the only
many
indication of
obesitians with PCO and obesity, they prescribe metformin.
Yeah, I'm talking about that only. The only indication where metformin has been considered is if you have established polycystic ovarian syndrome or if you have non-alcoholic fatty liver disease. These are the two, and of course diabetes. These are the only three indications. FDA approval is only for diabetes. So Dr. Ahila is very, very precise when she's saying that metformin is not recommended in obesity. But yes, many guidelines suggest in metformin, as Dr. Ahila herself mentioned, in those scenarios like PCOS, you may consider. But metformin is not a weight loss drug. This is what I'm going to tell you about that. It is going to cause maximum 2-3 kgs decrease in weight. You won't get too much weight loss. I have used a lot of older GLP-1 receptor analogs like dulaglutide, liraglutide. They cause around 5 to 10 kilograms weight loss. Orlistat is like 0 to 2 maximum. Semaglutide, the injectable version, which is now available in the US, is supposed to cause 10 to 15% loss in BMI SDS. So we are waiting for that agent to come in, but only for morbid obesity. But we are seeing now those cases, 100, 120, 130 kgs. You have to think something about that. So yes, these are very difficult cases, but don't prescribe metformin just as an anti-obesity medication. It's not going to work. It's not recommended.
I use it in pre-diabetes.
Yes.
Have a HbA1c which is high. They are on the way to be developing diabetes or insulin resistance, which I have proven. Then I use metformin. Definitely I use so that to stop the progression onto type 2 diabetes. I'm using oral semaglutide in those 167 kgs because that's the only one available in India.
Yeah.
Dr. Ahila, your favorite thing, what is the, gone are the days of STOS therapy. What is the current management guideline for vitamin D management?
Yeah. So even the IAP recommendation, I feel is a little bit too much. So I still go with the international recommendation where we give 150,000 units is the maximum dose we give for treatment of severe vitamin D deficiency rickets. Otherwise, we go by replacement doses, which is given in the chart. So even that, I don't like to give it as a single 150,000. We have 60,000 units. So I probably give it once a week. But in obese children, where I feel that the deficiency is severe, it may not be able to replace enough. I've gone up to 4 to 6 doses. And then you have to continue with replacement doses. So less than 1 year of age, it's 600 international unit is the RDA that is required, and beyond 400 units up to 1 year, and beyond 1 year, 600 international units per day. But during treatment, I go up to 800 to 1,000 or sometimes up to 1,200 international units per day. But if you're going to start the replacement dose as an everyday dose, you can even go up to 3,000 to 6,000 international units every day without giving STOS therapy. But remember, rickets can happen due to vitamin D deficiency or calcium or both. So you have to replace both.
Okay, you have to add calcium too.
Yes, because we always forget that you can have rickets because of calcium deficiency also. So it can be vitamin D deficiency or calcium or both.
The last question before completing the thing, and early, that is ketotic hypoglycemia in a toddler. We come across many babies about 1 to 1.5 or 2 year thin babies coming with a early morning lethargy and not able to awake. And the baby, when you do the blood glucose, it will be around 40, 30. That is the ketotic hypoglycemia of a toddler is a common problem by a practitioner faces. Whether we should evaluate further or whether we can say whether he has to be fed properly in the night or before going to sleep.
Any child with hypoglycemia beyond the 48 hours of life is significant. You cannot assume that this is ketotic hypoglycemia. You need to think of pathological causes. So ketones are very important. If ketones are positive, then you have to look at further evaluation, whether this is a glycogen storage disease. Look for hepatomegaly, lactate levels will help you out. Then if there is no organomegaly, lactate is normal, go for cortisol level. And only after you excluded cortisol deficiency, multiple pituitary hormone deficiency, should you think that this is ketotic hypoglycemia. So answer to that is yes. Most of them, 95% of them will have ketotic hypoglycemia, but some of them may have GSD or very rare forms of GSD you need to evaluate. After that, of course, you have to say, okay, build up their nutrition, build up their muscle mass, nighttime proteins, and particularly during illness, they would need to be very, very carefully managed in terms of glucose monitoring in that perspective. So this is one phenomena which is common. But as I said, endocrinology is all about physiology and pathology. You don't want to miss pathology in the name of physiology, while at the same time you don't want to do unnecessary investigation. But yes, I would definitely recommend evaluation, at least baseline, to exclude cortisol deficiency and GSD in that scenario before you label, because then you're not going to do anything. And the child may come back again with severe hypoglycemia in that regards.
So it is a diagnosis of exclusion. Okay.
It's a diagnosis of exclusion.
I just want to emphasize 2 points for pediatricians. If you can buy a glucometer, which also has ketone strips, it's extremely useful. Your Optium Neo H, your On-Call Plus, all of these glucometers have ketone strips, which can be used in the same glucometer. Measurement of serum blood ketones is extremely useful in evaluation of both hypoglycemia or diabetes, any of these subjects. So if you can, all pediatricians have a glucometer with ketone strips, it's very, very useful in the clinic. Then draw a critical sample and keep it. It may be useful, it may not be useful, but you need not induce hypoglycemia again to get a diagnosis. If you think this child is going to need significant evaluation, baseline, when the child arrives in hypoglycemia, before you give your dextrose push, just take some bloods, put it in some serum tube, some EDTA tube, and put it in the fridge, and then treat the child, and then think of what you want to do with the samples after that. I think that is one request I would have for pediatricians. To take a critical
usually during the routine, during interpretation, some labs they give 1+2+ ketone positive. Is it really worry, especially during the starvation or persistent vomiting? Is there a need to worry about this, or it is a self-limiting?
It's a compensation mechanism. You don't have enough glucose in your body, so the body is trying to produce fuel from some other sources. That's why ketones have come in to give you fuel. So it is a compensatory mechanism. So that is not the most worrisome one. But if it is significant hypoglycemia, age dependent, draw a critical sample, look at it. If it is a ketotic or a non-ketotic, use the critical sample to evaluate baseline values. And if they are reasonably okay, and the history is extremely important. Like Anurag mentioned, what happened the previous night? When did the child eat? Did the child have vomiting or diarrhea? What was the sleep? What time did it get up? All that will give you clues on what the diagnosis could be.
Madam, critical sample la engalukku theriyadu madam. Critical sample la enna solunga.
Oh, so when the blood sugars are low, take bloods for take a blood for glucose also. It has to be measured in the lab to reaffirm your diagnosis. So blood for glucose, insulin, cortisol, growth hormone, lactate, ammonia, and keep some other samples for the rest of the test if you need.
Oh. Madam, you can go ahead with the presentation.
Ketones is the most important one. If you get a ketotic, non-ketotic hypoglycemia, there are only 2 reasons, usually. One is fatty acid oxidation defect, then is hyperinsulinemia. Hyperinsulinemia, the child will be big.
Yes.
It will take food, it is an anabolic hormone, it will build up the baby. The child is thin and has a non-ketotic hypoglycemia, think of fatty acid oxidation.
Okay. Madam Aguila, madam, you can go with 10-minute short presentation of head-to-foot clues for the thing, because there are only 10 minutes left. Ramanathan, you can take the questions finally from the chat box. What are the things which you are left? Yeah, finally we can take after this is over. After this is over, madam, presentation is.
Okay.
So we'll go. I just thought I'll show some interesting pictures. So this is something which we always read about, hot cross bun. So this is the hot cross bun, and this is the hot cross bun appearance, which you see in vitamin D deficiency. This is the costochondral bleeding. This is the bent limbs. These are nutritional rickets. So this is the picture which you traditionally see where this child is referred as a micropenis. Look at the scrotum. It's going up to there. So this is called a slightly prepenile scrotum, not truly in the sense. And when you push the skin back, you can see a normal size penis. So this is called a prepenile scrotum, but not fully. But sometimes in short stature, you will think of Arscough-Scott syndrome. This is a child who came with breast development at 1.5 years of age and has a huge Kaplan spot. So this gives you a clue for McCune-Albright syndrome, and this child is currently under our treatment. Okay, so this is a mother. This is the hands of the child. So this child has come for short stature to us. You bend the hands, look at the knuckles. You can see each of these, but you can't see that in this girl, in the last two segments. So that is a short fourth and fifth metacarpal, which is a part of a Turner syndrome. Always we look at the hands because we were always taught about short fourth metacarpal. It's quite common. You should ask them to take off. Most of them are wearing shoes nowadays. Ask them to take off the shoes. You will see a short fourth metatarsal, which is much more frequently seen than short fourth metacarpal. Remember, short fourth metacarpal is a clue. It is not the definitive diagnosis. You can have short fourth metacarpal in several diseases, including Turner's. You can have in pseudohyperparathyroidism. I've got one child with Coffin-Siri syndrome, in multiple exhaustosis. There are any number of scenarios where you can get Noonan syndrome. So you can have short fourth metacarpal in all of these. So this is the webbing of the neck. You have to stand at the back. You can see the webbing much more clearly. This is another girl with webbing of the neck. All girls with webbing of the neck does not mean have Turner syndrome. Look at this. This is the hands of the family of the girl, the second girl with the webbing of the neck. This is the brother, this is the mother, and this is the girl. So this is not a disorder of Turner syndrome of the X chromosome. This is an autosomal dominant disorder. This child comes from a family of Noonan syndrome. This is an extreme webbing. This is something not many people would miss. This is the shield chest. Look at the scar from the cardiac surgery that she had. This child is going to undergo plastic surgery because she's extremely, now she's attained menarche and she's very upset about that neck and her appearance when she goes out. So she's going to have plastic surgery for this severe webbing. I think a lot of people, I actually focused after Dr. Palniraman said he wanted a picture of an almond-shaped eyes. This is a typical almond-shaped eyes in a child with obesity who had severe hypotonia and feeding difficulties in the first year of life, and then started putting on weight after 2 years of age. This is acromicria, small hands and feet in the same child, not the same child. These are the same diagnosis in several children. And this is an important clue in girls. The labia minora may not be seen at all. It is severely hypoplastic in these children with Prader-Willi syndrome. So all of that, acromicria, almond-shaped eyes, and hypoplastic labia are all part of Prader-Willi syndrome. This is a child who's 5 months of age. Head control is almost there. Child is heavier. A big umbilical hernia or an exomphalus, a protrusion of tongue, small clefts in the ear or pits in the ear, a typical Beckwith-Weidman syndrome. So this is an obesity with post-axial polydactyly. So this is about the feet also were the same. I just put the hands and feet alone. This is a typical Bardet-Biedl syndrome. They have a defect in the BBS gene and loss of vision is a major feature. Now we say visual rehabilitation when they have vision is important to help them look after the life well in later life. So this is a boy who's 17 years of age who came to us with short stature. This is too late. Anurag also showed a similar picture. So this partial ptosis, clinodactyly, a triangular facies, a typical Russell-Silver syndrome. This child had come with short stature. Then you put both the, you can approximate both the upper limb together. Cleidocranial dysostosis. So this is another child with the typical eyes, anti-mongoloid slant. This is called persistent fetal pads. Persistent fetal pads, severe hyperextensibility, partial ptosis, inverted lateral half of the lower eyelid, low set ear, short stature, hypogonadism, a Kawuki syndrome. A tall boy, 9-year-old boy, as tall as his dad, with an ectopia lentis, a Marfan syndrome. You don't need genetics to diagnose Marfan syndrome, but this is 3 boys who are tall. I put them across with the parents. He's very tall. He's got a difficulty in education, started becoming an introvert. This boy is tall. He ultimately reached a height of 195 centimeters. The dad is 187 centimeters. This boy has now reached 195 centimeters in 12th standard. So this is Marfan's, this is familial tall stature, and this boy had homocystinuria. So how will you differentiate between all of this? Revised Green's criteria is the diagnosis, is the way to make a diagnosis of Marfan syndrome. Russell-Silver syndrome is usually using Netschin's criteria. So these are all clinical diagnoses rather than genetic diagnosis. In Russell-Silver syndrome, only 40% will have 11p15 hypomethylation and 10% will have uniparental disomy. 50%, the other 50% will still be a clinical diagnosis. So this is a sinophrys and a syndactyly and a Cornelia de Lange syndrome. And this is the way I thought I should show how we make palpate a gynecomastia. Thanks.
Thank you very much, Dr. Aguila and Dr. Palniraman and Dr. Ramanathan. Would you like to take any other questions or?
Ramanathan, question left.
Most of the questions have been answered, sir. All the questions have been.
PRC sir, Ashwath has asked management of type 1 diabetes during Ramzan in a Muslim adolescent.
Okay. So we are actually having quite a few of our children doing Ramzan fasting. So we reduce the long acting a little bit. They have their morning food. When they are on analogs, it's quite easy to manage. They have their breakfast quite early at 4 a.m. They take a dose based on their carbohydrate counting. And then the next dose will come in the evening when they're breaking their fast. They monitor their blood sugars to adjust their long-acting insulin based on their blood sugars.
Anurag, doctor, role of oral calcium in newborn with jitteriness. Unmute, please. Unmute, please.
And generally, we don't.
Unless
you have calcium deficiency, we should not routinely give oral calcium. The major cause here is actually because of vitamin D deficiency, which can cause that. So if a child actually has jitteriness because of hypocalcemia, we should correct it using injectable forms. If the calcium is normal, there is no role of giving oral calcium.
There is one question from Dr. PRC. Normal TSH and FT4 with the presence of thyroid antibodies and goiter. How do you proceed?
Wait and watch.
Wait and watch.
In a febrile child, frequently getting acetone 3+, 4+ is due to starvation or any other thing?
Mostly starvation. Get starvation. Blood sugar done. I think that will be the first thing.
Okay. Implication of asymptomatic hypoglycemia incidentally picked up on the glucose sticks.
This is usually seen in obesity. Because it's insulin resistance, they'll have fasting hyperinsulinemia, they may have a bit of fasting hypoglycemia. If it is asymptomatic, I don't think there's any role, and it should be age-specific criteria for diagnosing hypoglycemia, as Anurag had already mentioned. It cannot be just a random number.
Balashankar sir, ungo side learned.
No, sir, nothing. As usual, this was very interesting and enlightening deliberation. So many doubts what we have in practice has been addressed. And I really thank the specialists, both of them, Dr. Bajbai as well as Dr. Akila, who have done a wonderful job and made this topic so simple, which is really complicated actually. So they made it so simple and they have answered almost majority of the doubts what we have in our practice. Thank you very much, panelists. Thank you, Ramanathan sir and Palniraman.
Another one more question, Aguila, before winding up. They have asked when to take the thyroid sample, whether in an empty stomach or 4 hours after the child taking the tablets.
I always take it before taking, not the food, before taking the tablets in the morning on that day, because the T4 will influence the results and it may confuse your evaluation. So I always do the blood test before taking the tablet on that day morning.
Thank you, Dr. Anurag, for a wonderful thing. Thanks for coming and thanks for accepting our invite. And Aguila, as usual, fantastic. Thank you, thank you. Rams, your final words.
Thank you, sir. Thank you. This has been a wonderful session, and we were able to cover quite a few topics in this limited time which was given to us. Thanks for the wonderful presentation by Dr. Anurag and Dr. Ahila Ayavu. I think we should have a session 2 to cover the remaining DSD and other things. I think that has not been covered enough.
Yeah.
Disorders of sexual development and other things, hypocalcemia, those things I think we should cover in a more detailed way in session 2. Thank you, Dr. Anurag, and thank you, Dr. Ahila.
Thank you very much. Thanks for all the participation and thanks.
Thank you, everyone. Thank you.
And thank you very much. I think it was a brilliant session. Nothing more to say. So we hope to see you sometime in future. So thank you very much, everybody.
Thank you, sir. Thank you.
Good
Thank
night.
you,
Good
Anurag.
night. Thank you, sir. Thank you,
Thank
sir. Thank you.